The Akron Roundtable is pleased to host Dr. Lewis Sullivan, former Secretary of the U.S. Health and Human Services, who will speak about transforming the health profession, turning mission into action. I will now ask Dr. Jay Gershon, President of the Northeast Ohio Medical University, to introduce our speaker.
Thank you, Mike. And I'd also like to thank the Akron Roundtable for reaching out to NeoMed and the Sullivan Alliance to sponsor today's event. Before I begin the introduction of today's speaker, I would like to share that the Honorable Louis Stokes, dear friend of Dr. and Mrs. Sullivan, is in the audience today. Let's recognize Congressman Stokes for all he's done for Cleveland, Northeast Ohio, and our country. It is my honor and pleasure to introduce to you a man who is a visionary, an initiator, an innovator, a medical educator, a tireless public servant, and a marvelous human being. He has worn many hats in his life, most notably President and Founding Dean of Morehouse School of Medicine, an institution he led for more than 2 decades. And, as you heard, an appointment by President George Herbert Walker Bush to serve as Secretary of the Department of Health and Human Services, a cabinet position overseeing major health, welfare, food and drug safety, medical research, and income security for our great nation. In this role, our speaker led the way to improve the health and health behavior of the American people. A native of Atlanta, he graduated magna cum laude from Morehouse College and earned his medical degree cum laude from Boston University. Our speaker is a member of numerous medical organizations and is a recipient of 60 honorary degrees. And I'm delighted to report that tomorrow he'll receive another one from NeoMed. He has served on numerous corporate boards, including General Motors, Bristol-Myers Squibb, Cigna, and United Therapeutics. Dr. Sullivan has served as chair of the President's Commission on Historically Black Colleges and Universities, and he was co-chair of the President's Commission on HIV and AIDS. He is particularly proud of his work as chair of the board of the National Health Museum in Atlanta, whose goal is to improve the health of Americans by enhancing health literacy and advancing healthy behaviors. In 1985, our speaker was one of the founders of the Medical Education for South African Blacks and led the way to raise scholarships for more than 10,000 Black health professional students, including physicians, dentists, and nurses. I've had the honor to work with our speaker on the boards of Research America and the Sullivan Alliance to transform the health professions, which is an organization dedicated to diversifying America's healthcare workforce. In fact, one of the lead projects of this alliance is an initiative based right here in Northeast Ohio, where NeoMed is working with other universities, as well as hospitals, foundations, and philanthropists in the region to raise scholarship dollars to provide a free medical education for students in exchange for a commitment to practice in underserved urban and rural areas. I have known our speaker for over 20 years, and I'm proud to call him a colleague and friend. Please join me in giving a warm Northeast Ohio welcome to the Honorable Louis W. Sullivan.
Jay, thank you very much for that generous introduction. And among other things, I'm pleased that friend and colleague of many years, Congressman Lou Stokes, could be with us today. And I'll share with you the fact that I was in Atlanta, heading the Morehouse School of Medicine. We formed in 1977 an organization called the Association of Minority Health Profession Schools, which was a 12 institutional membership organization, including the Black health profession schools in the country. So we had Tuskegee Veterinary School from Alabama, the Texas Southern University School of Pharmacy in Texas, Florida A&M College of Pharmacy in Tallahassee, Hampton University in Virginia, Howard University in the District of Columbia, and Meharry Medical College in Tennessee. So none of us were in Ohio, but each one of us and all of us were always visiting Congressman Stokes in his office because he was on the Appropriations Committee. So we always had issues that were of concern to us, and in spite of the fact that we couldn't vote for him, he always was supportive of what we were trying to do, and he did it very well. Not only his own activities, but through him we got to know a number of members of Congress who worked with us. Silvio Conti from Western Massachusetts, Republican. Paul Rogers from Florida, who chaired the Committee on Health, Energy, and Commerce. So, Lou, I'm pleased that you could be with us today. And so, and I always voted for you, but they didn't count my vote. Well, first of all, let me begin by thanking the Roundtable for inviting me to speak to you today, because I'm very much aware of and impressed by the impact of your work in this community and indeed throughout Ohio. For that reason, the title of my remarks, as you've heard, is Transforming the Health Professions, Turning Mission into Action. Well, there's vital and immediate need because the Affordable Care Act, which was passed in March of 2010, is designed to increase access to health of Americans, as well as to increase the number of well-trained health professionals. And as you know, this act was designed to provide insurance to some 30 million Americans who were previously uninsured. When I was secretary in 1989, we had 37 million uninsured Americans. And in spite of the robust economic expansion of the 90s, by the end of 1990, we had 47 million uninsured Americans, showing that having economic prosperity does not automatically guarantee access to health care. It takes deliberate actions that were taken by the President and the Congress, and I'm pleased that in spite of the efforts of many over the decades, we finally have the Affordable Care Act. So now, there are fewer uninsured Americans. The growth in the newly insured has already begun to challenge the healthcare system because we're bringing more people into the system. We saw the same in Massachusetts when they initiated and passed their health reform bill, so that now 99% of the residents of Massachusetts are covered by health insurance, but they have to expand the capacity of their health professionals in the state. Well, our country's demographics are changing because today, African Americans, Latino Americans, and Native Americans make up more than 30% of our nation's population. And when we look at Americans under the age of 20, we find that those minority percentages actually total 43%. Further, the U.S. Census Bureau projects that with the changing demographics in our society, by the year 2042, there will no longer be a majority population in our country. A report recently published by the Association of American Medical Colleges states that by the year 2025, our country will face a shortage of physicians, a shortage of between 46,000 or as many as 90,000 fewer physicians than are needed. And most experts emphasize that a culturally competent healthcare workforce is essential for the optimal delivery of quality care. And when we look at our health professions today, we see that they look differently from the population at large. Because although African Americans, Latino Americans, and Native Americans make up more than 30% of our nation's population, when we look at the health professions, less than 13% of our health professionals are from one of these minority groups. And because our nation's communities are becoming more diverse, we need to train more diverse and culturally competent healthcare providers to care for our citizens. As I often say, an optimal outcome with the health professionals in our society require well-trained individuals who are scientifically based and competent, but also individuals who understand the culture, the value system, the lifestyles of the patients with whom they work so that they can communicate effectively with them. They can be understood and trusted and therefore increase compliance with the recommendations of the health provider, including filling prescriptions, returning for a visit, and following other instructions. Yet, against this backdrop of obvious need and the dramatic statistics, how many of today's minority students in our cities and towns in elementary, middle, or high school dream of a career in the health professions? For many, it's not even a flicker of an idea. And for many others, there is an insurmountable financial mountain to climb to become a health professional. Because of this glaring gap between need and action, in the year 2005, we formed the Sullivan Alliance to transform the nation's health professions. Our organization is guided by two significant reports and their recommendations published in 2004. One, the Sullivan Commission, which was titled Missing Persons, Minorities in the Health Professions. And the second report was from the Institute of Medicine, entitled In the Nation's Compelling Interest, Ensuring Diversity in the Healthcare Workforce. Now, NeoMed's president with us today, Jay Gershon, was a member of the Iron Study Committee and is also a founding board member of the Sullivan Alliance. And in that capacity, his advice and his guidance is much valued. So Jay, thank you for your contribution to the Sullivan Alliance. Now, the Alliance has established operations in 8 states focused on diversity initiatives that enhance the health professions pipeline. And although there continues to be lack of a comprehensive federal response to these missing connections between community, education, and healthcare delivery, there are examples of true commitment and real change being implemented at the state and community levels. Efforts that will ensure a robust education pipeline which delivers more well-trained health professionals, committed to living and working in underserved communities that need them. The Ohio Alliance, which was formed as a result of some of the activities that I'll outline today, is such an alliance and is a key partner in our national efforts. One of the most successful and comprehensive and creative efforts is what has been undertaken by NeoMed and the 21st century leadership that Dr. Jay Gershon is providing, with a consortium of academic institutions and an entire community committed to helping support and produce primary care physicians who will return to serve in the underserved in urban and rural communities. NeoMed's Education for Service program creates a pipeline of students from economically, educationally, and culturally diverse backgrounds for the health professions. And it is based on 4 important elements: the pipeline, curriculum, community engagement, and scholarship. NeoMed has established multiple educational pipeline programs, and through their consortium partnerships, admittance of underrepresented minorities in NeoMed has increased 5-fold, which means that 24% of NeoMed's pipeline students are minority. This is significantly greater than the rate for other medical schools across the country, which averages about 15%. These Ohio academic and community partnerships are focused on delivering new primary care physicians to Ohio communities. Up to 35 medical student seats at the College of Medicine are allocated for each consortium school: the University of Akron, Cleveland State University, Kent State University, and Youngstown State University. It's important to note that all of NeoMed's programs and efforts are focused on training tomorrow's health professionals, training them to be part of the interprofessional delivery teams that the country needs. Interprofessional training and interprofessional care delivery results in better health care and better health outcomes for patients. We need more primary care physicians, but we aren't expecting everyone to become a physician or a dentist, a nurse, or pharmacist. There are many health professional paths available and critical to the culturally competent health delivery teams of the future, focused on primary care and preventive care. I'll give you an example. Oral health underpins all of health. The mouth is an important part of the body. Dental health is an important part of overall health. Millions of Americans, adults and children, do not have access to routine dental care and preventive services. And over the past 20 years, the number of dental health professional shortage areas in the country has grown sixfold, from nearly 800 such shortage areas in 1993 to more than 4,900 in 2014. Dental caries disproportionately impact low-income and rural populations in the U.S. Dental caries are the most common chronic disease in children. More than 47 million people live in places where it is difficult to access dental care. And more than 14 million children who are low income received no dental care in the year 2011. Low income adults are also twice as likely as higher income adults to have gone without a dental checkup in the prior year. More than 1/4 of adults in the U.S. aged 65 and over have lost all of their teeth. But the Sullivan Alliance has partnered with state leaders across the country to change these overwhelming statistics on oral health access. And just as we need more primary care physicians, certainly we need more dentists. Current numbers from the Health Resources and Services Administration indicate that we as a country need 7,300 new dental providers in order to meet the country's oral health care needs. We need to increase the number of dentists from diverse social and ethnic backgrounds. Less than 8% of students enrolled in dental school are either African American, Latino American, or Native American. And only 14% of dentists are from racial or ethnic minority populations. And of course, training new dentists takes time. And we hope that the new dentists who are trained will want to practice in areas of need. However, dentists joining the National Health Service Corps program have, on average, debt of $142,000 from student loans, more than 10% greater than the average for graduating medical students. And while we can hope and expect these new dentists to bring passion for their profession and their commitment to care for their fellow citizens, what is their financial incentive to locate practices in these dental shortage areas? We must consider additional models of dental care if we are to meet the oral health needs of our citizens. One proven model is that of the dental therapist. Similar to nurse practitioners and physician's assistants in medicine, dental therapists are professionally trained mid-level dental providers who can help people get the dental care they need. They supplement the work of the dentist and can work in different locations, often using telehealth technology while under a dentist's supervision. And when dentists are in short supply, dental therapists who receive more clinical hours of training than dental students do on a specific number of routine and preventive procedures, these therapists can expand the reach of dentists and provide vital dental services. They provide oral health education and preventive services and offer continuity of care for the underserved. Dental therapists are trained to provide a limited scope of routine services, including preventive care, such as patient instruction, oral health outreach, and oral screenings. They provide dental examinations, x-rays, and fluoride treatments. They provide cleaning and placement of dental sealants. They provide fillings for dental caries, as well as performing simple extractions. Well, these mid-level providers have been in place in other countries, such as Canada, the United Kingdom, Australia, and New Zealand, for as many as 90 years in these countries. In fact, in New Zealand, a school-based dental delivery system using dental therapists has been in place since 1921, almost 100 years. In the United States, Alaska Native tribes have led the way in establishing the first dental therapist model to care for children and families in Alaska in 2003. They served in Alaskan villages that are so small and remote that no dentist could establish a full-time practice there. And here in Ohio, you have the Universal Healthcare Action Network, or UCAN Ohio. This is leading the effort to bring oral health access to Ohio citizens through their Dental Access Now campaign. And I salute them for their efforts. So in the 21st century, we need new models of care. We need new types of healthcare providers, new uses of technology. All are elements that will result in improved health for our citizens and ultimately will reduce healthcare costs. Changing and enhancing the pathways to the health professions is vital. And what you have underway here in Northeast Ohio is a significant best practice. Another element that makes the Northeast Ohio primary care model unique and successful is the level of community engagement reflected in the clerkships and the training resources you've made available. Many Akron healthcare facilities, including Suma Health System, Akron General Medical Center, and Akron Children's Hospital, the Akron Health Department, the County of Summit Alcohol, Drug Addiction, and Mental Health Services Board, and many local pharmacies and healthcare centers serve as training and clerkship sites. Now, this is a smart community investment. At NeoMed's recent match day, 32 students received residency offers with healthcare providers here in Akron. Conversion rates from residency to practice among these trainees are around 50%. With each doctor's practice generating an average of $1 million annually of economic activity in the community. The American healthcare marketplace is undergoing change and is in need of continuing reform. We need state, federal, and private support to encourage more young people to enter the health professions and address the need for healthcare providers in our underserved rural and urban areas. America's health professions must embrace new models of care to meet the needs of the underserved and our diverse populations. To continue the improvement of the health, the economy, and the quality of life in Northeast Ohio requires ongoing efforts. Your hard work is critical to the future of Akron, of this state, Ohio, and our country. So I want to thank all of you who are involved for the opportunity to be here with you to note of these activities underway, and I salute you for all of them. Thank you very much.
Dr. Sullivan has graciously agreed to respond to written questions. There are no cards at your table. If you'd like to write down a question and hold them up, they'll be collected and presented by our board programming chair, David Hunter.
Dr. Sullivan, we'll start off with this question. In your remarks, you had forecasted a grave shortage of personnel, physicians, and others in the healthcare industry, and you took time to outline in detail some of the initiatives that forward-thinking medical schools like NeoMed are undertaking to enhance diversity, to expand service to the underserved here. But isn't there another element to this too? That'll promote diversity, but how do we address the shortage issue? Will medical school classes need to be larger? Do we need more medical schools? Perhaps you could give us some insight on that.
Yes, thank you very much. Yes, my answer to that is we need more health personnel, while at the same time, we do need to work to improve the efficiency of the healthcare system. Because bringing 30 million more people into the system is going to increase the demand for services. What we have now is unmet need, people going without because either they have no health professionals or they don't have health insurance or other factors, including the fact that they may feel that they're not welcome at a hospital or a doctor or a dentist's office, etc. We need to have those people get the services they need so that they will be healthy, so they can be productive, they can be working, earning wages, paying taxes, and contributing to the economy, rather than being disabled by injury or illness and requiring social services. In the second half of the 20th century, we saw in this country a remarkable expansion of medical schools and other health profession schools. NeoMed is one of those schools. In 1950, we had 80 medical schools around the country. Beginning in 1956, with federal leadership, we opened 47 new medical schools, of which NeoMed is one, and Morehouse School of Medicine is one also. Funds were available from Health and Human Services, from the Veterans Administration. 7 of those schools were supported with VA funds, 2 with Department of Defense funds. Wright State Medical School was one of those supported there at Wright-Patterson Air Force Base, and the other Uniformed Services University. Today, in contrast to what happened between 1956 and 1981, we have a few new schools opening, but those are primarily state-led efforts and a few private efforts. We don't have the federal government providing the kind of leadership and support that we had between 1956 and 1981. So yes, we will have the need. We also need to reduce the inefficiency in the system and a number of other things. So we really do need more personnel, but we also need to husband the dollars that we have and use them more efficiently.
One of the great aspects of our forum here is we always get very thoughtful questions from our engaged audience, and today is certainly no exception. Here's a rather specific question. With the huge impact of lifestyle-based chronic illness on community health, are physicians now receiving more training in nutrition than in the past?
Well, very good question, and I certainly agree that we need to have much more in the way of preventive services. We are receiving more training in nutrition, but not enough. Curricula in health profession schools are changing, and certainly emphasis on nutrition is important. Such things as high blood pressure, heart disease, cancer, diabetes, obesity, arthritis, these and many other conditions are affected by lifestyle, including nutrition. We now know, compared to 30 or 40 years ago, that such things as regular routine exercise has health benefits. 40 or 50 years ago, this was thought to be a feel-good activity that had no consequence, but we now know people are physically active, live longer, have low incidence of heart attack or stroke. If they have high blood pressure, it's more readily controlled. If they're diabetic, their diabetes is more readily controlled. So yes, lifestyle, prevention, health promotion, all of these have an important role. And it also means that each person as an individual has a responsibility for helping to maintain their own health. Because if you have a problem with obesity or diabetes, there are things that the individual must do. So we're really shifting from a hierarchical system in healthcare of having the doctor dictate everything and the patient being a passive recipient of knowledge and instruction. But the patient now has to be very active. So this is a good example of that.
We have several questions regarding diversity, so excuse me, we're going to go back there. You spent a great deal of time discussing the need for diversity. How do you respond to people, often in positions of authority, who either do not value diversity or see the need for diversity?
I tell them that they don't understand the whole picture. I alluded to the dental therapist program, which was started by the Alaska Native Tribal Council. It was not started by health professionals. And in fact, unfortunately, my colleagues in the American Dental Association have fought this because mistakenly, they see this as a threat. Well, in medicine, we had a similar kind of fight back in the 60s and 70s when physician's assistants, nurse practitioners were introduced. Today, that fight is over in medicine. Physician's assistants, nurse practitioners are integrated into the system, they're valuable, and they extend the reach and the capacity and the income of physicians. So I see the same happening in dentistry. Now, part of effective care means being able to communicate effectively between the patient and the healthcare provider, because if you don't understand or don't trust the provider, then you're not going to share all of those sensitive things that the provider needs to know if he or she is to really make an accurate diagnosis or develop an appropriate plan of action. So diversity is important. It is not simply, it is certainly the right thing to do, but it's more than that. It's a smart thing to do. So that's why this is important, because if you don't understand what the physician says, or if you are intimidated and you don't have a good exchange, then that's not really the best outcome. So that's why diversity is important. And also the fact that in a mere 20 years, we're going to be a very different society ethnically. We need to have much more diversity among our nation's health professionals.
You made mention in your remarks to the Affordable Care Act that was enacted in 2010, and we're all aware of the fact that it's a provocative piece of legislation, a broad array of views on its benefits and what people say are its detriments. What sort of changes, if any, would you like to see in the Affordable Care Act, and what do you forecast that legislation may ultimately look like, say, 5 years from now?
Good question. Before I respond to that, let me just point something out. We spend, as a country, more dollars in our healthcare system than any other nation. More dollars in absolute terms and more dollars in per capita terms. We have the strongest health professions educational system in the world. We have the most innovative, creative biomedical research enterprise in the world. We've developed more new drugs, more new therapies than any other country on earth. We've had more Nobel Prizes come to scientists in American laboratories in the 20th century than in the rest of the world combined. With all of that, we fall far short when it looks at the health of the nation. We're not number one. We rank anywhere from 10, 15, even 30 by various health indices. You look, who are the nations who have the best health statistics? They are the nations such as Denmark, Norway, Finland, etc. And these are the nations that we model it. Well, they have a system where there is broader access to health insurance. And if health is important, I think as we all agree, we need to do those things that will make us healthier. I think those who really resistant to the healthcare program really don't have that view. They have a much narrower view. So I support the legislation. Now, it is certainly not perfect. First of all, I believe we should have a different medical malpractice system. I advocate for a no-fault malpractice system, because right now it's really a lottery. We have a system that drives physicians, hospitals, clinics to cover the chart when they have someone with an illness, doing all kinds of tests that really are not necessary, but they're afraid, well, if there's an adverse outcome, I want to be prepared in case I'm sued. So that's wasteful. and the amount of time and the lawyer's fees involved, et cetera. If we were to have, for example, expert panels of healthcare providers, community representatives, lawyers, et cetera, to really review cases and decide them on the merits, rather than spending all this time in the legal system, that would be one thing. We also have fraud in the system. And unfortunately, as much as 20-25% of the dollars wasted or go to fraud. So those are the things that we need to work to address, because the system is far from perfect. But I say it's like a journey of 1,000 miles. It begins with the first step. Let's work with what we have, knowing it's not perfect, but don't use that as an excuse to try and get rid of it. Let's use that as a strategy to improve it. And we will be better off as a nation, because if we are hobbled by illness and injury, in a few years we won't be the #1 country in the world in terms of our economy, our innovation, our productivity, et cetera. That's why health is so important. So those are some of the things that I would improve. What can
As we're comparing our system with those employed by other countries, if you look at our system, and one of the cornerstones, of course, is insurance. And how would you respond to those who say that with insurance being the cornerstone of our system, it cultivates a certain insensitivity by the consumer of medical services, who are really not paying attention to the cost of that? So how do we guard against runaway increases in medical services in a system like that?
Very good question. I think that's a very legitimate question. I believe this is the importance of what you call co-pays. In other words, this should not be set up as it is that you lose a sense of the value or the cost of this. But if the patient or the individual purchasing the insurance really also has skin in the game, that is, if you have a procedure or something done, it is not covered entirely by the insurance, but you pay a part of it. It shouldn't be so high that it serves as a disincentive to get care, but it really serves to keep the person involved in thinking through and not doing something without thinking it through, because they feel that it doesn't cost them anything. So that's a mechanism. And I talked about improving health literacy. That is, we need to have better understanding of human biology, but also a better understanding of how the health system works. We have people who use the system inappropriately. They wait and get sicker and sicker and sicker until then rush into the emergency room, and it costs then $1,000 or $1,500 for something which would have cost $100 or $150 in a doctor's office. And it clutters our nation's emergency rooms. The continuity of care in that kind of arrangement is not as good as seeing a doctor or a nurse or a pharmacist out who really has a relationship. So we have to use our system more intelligently than we use it, but we also have to have a system that indeed keeps people aware of the fact that this does cost, but it should not be, the copay should not be so high that it really inhibits use.
As is always the case when we have a stimulating speaker, we have more questions than we have time to cover them all here. But we have 3 more questions we'd like to ask you. In your remarks, you made reference to the numbers of uninsured people in the country, noting that there were about 47 million in the 1990s. A member of our audience would like to know if you could share with us, if you know, what the current level of uninsured people may be in the United States, especially in light of the enactment of the Affordable Care Act.
Well, good question. I can't give you the precise number, but what I can tell you is we now have some 15 or 16 million people who did not have health insurance before, who now do have it. After the first round, I think we had some 6 or 7 million people, but that has continued to grow. We did have a glitch when the system was introduced, and I think that was a mistake in educating the public on the part of our leaders in the administration, because what happened, as you know, many of the exchanges didn't work. And so therefore, those who were opposed to the system said, well, see, the system's so good. Well, I happen to have served on the board of Grady Hospital at our big public hospital, About 4 years ago, we put in an electronic health system by a well-established company that had worked for this for years. They flipped the switch, guess what? It didn't work. But we didn't throw the system out. We worked on it, and it's now working, and costs are coming down. The quality of care is going up. So I think that we have a large, complex system. We can't expect everything to work perfectly, but we need to continue to focus on it to improve it. So that would be my response.
We have time for 2 more questions. This possibly could have come from our students here in attendance today. And the question is, what motivated you to go to college and to medical school?
Well, thanks. First of all, I consider myself very lucky. I had parents who were very committed. I was one of 2 boys. My parents were very committed to us going to college. My mother was a college graduate, was a master's holder. My father dropped out of school after his 2nd year for financial reasons. When I graduated from medical school, he was congratulating me and told me for the first time that he had always wanted to be a doctor. I was stunned. I didn't know that. So I had 2 parents who really stimulated me, and I had other role models. I was born in Atlanta, grew up in rural Southwest Georgia. There was one black physician in Southwest Georgia, 41 miles south of where we lived. He was my role model. So from early years, I never had any doubt, any question that I was not only going to college, I was going to medical school. I was going to be a doctor. So fortunately, I had the support, and also that's one of the reasons that I do what I do, because I had many of my classmates in elementary and high school who didn't go to college, didn't become a doctor or whatever. They were just as smart, or even smarter than I was, but they somehow didn't have the support system. So we know we have the talent, but we have to support it, develop it, and if we do, the returns will be enormous.
You have had a stunning career, and I want to note, not only for our audience in attendance, but also our radio audience, in our pamphlet, we did not have sufficient room to list the numerous honors you have received, and I would invite anybody who'd like to see the complete bio to go to the Akron Roundtable website, where you can see Dr. Sullivan's complete biography. But I'll close with this question. Can you share with us, upon reflection, some of those honors that you value the most?
Well, thank you very much. There are a number, and I was very much on it. I guess one of those was an honorary degree I received in 2007 from the University of Pretoria in South Africa. The reason that was significant was you heard about the organization Medical Education for South African Blacks, which we formed with some others back in 1985. That was the time that the universities in South Africa were opening up to black students, but they were not offering scholarships. So these students, where it would cost them about $5,000 a year for tuition, room, and board, their families were earning an average of $500 a year. So an admission offer was almost meaningless. So that's why we formed that. So knowing that South Africa's history is similar in many ways to the history we had in this country of slavery and legally enforced segregation. And by the way, my father was very active in forming a chapter of the NAACP, starting an annual Emancipation Day celebration, and many other things, because when I was growing up, blacks couldn't vote in Georgia. They had the white primary. So in my lifetime, I saw a system that was oppressive, exclusive, and legally enforcing that kind of discrimination and segregation. So one of the things that my parents and many other parents said, this is a system that's wrong. We want you to work to really repeal it, to get rid of it. And I think we have made great progress as a country, and I'm very pleased with that, though we still have other things to do. But doing this in South Africa, and we did it because we felt that South Africa has great promise and could really serve as an anchor for the other countries on that continent, which is so impaired by weakness, corruption, illness, etc. So receiving that honorary degree was important, and another reason was one of our students, who was a graduate of Morehouse School of Medicine, who was from South Africa, had gone back to South Africa and was professor of surgery at the University of Pretoria. But he established the first nationwide blood banking system in South Africa, modeled after the Red Cross system, because they have a tremendous challenge from HIV and AIDS. And they had completed their first year of operation without a single case of HIV or hepatitis C transmission through tainted blood in that country. So receiving that really, for me, was very significant, but that is one of a number of things that I'm proud of. Thank you.